Welcome to this week's Doctor's Lounge. We are without Dutch Rojas. He is somewhere traveling en route to the Wizard of Oz, Land of Oz on our tornado. Hopefully he is safe, but apparently has no power. So we're going to be doing it ourselves. I'm Anthony DiGiorgio out of San Francisco, joined by Anish Koka in what I assume is sunny and wonderful Philadelphia, Sanat Dixit in Alabama, and Dan Choi out of New York, where things are calm, quiet, and wonderful. So, what news stories have stood out to all of you this week? Anish, you want to pick something and go first?
Yeah, I think there's a bunch of so many things. Where do we even start? I think the one that I was most triggered by, we'll say that. The one I was most triggered by was this New England Journal Perspective. Now, I don't know if people understand the New England Journal Perspective page is basically an op-ed, right? That's in the New England Journal of Medicine. The New England Journal of Medicine is like the Bible for all medical folks in the U.S. certainly, and maybe around the world. Features the greatest and latest research that comes out that is practice changing, right? Now, they have a op-ed page, basically, and their op-ed page isn't called an op-ed page. It's called the New England Journal Perspective page. And their perspective page has always been a certain ideology, we'll say, and that ideology is revealed in one of their perspectives. It talked about the direct primary care movement and the concierge movement, right? It was some assistant professor or some MD PhD who was talking about DPC, and they were talking, and concierge, and talking about the flight and the exit of physicians to the DPC and concierge model because of the many broken things that in the regular insurance-based model. And while they listed all the reasons why you may want to move, meaning you have more autonomy, you have less burnout, you may make more money, you don't have to deal with prior authorizations and utilization reviews. But what they wanted to focus on was the fact that making this a market-based decision, a free market, making it a commodity, making primary care a commodity, and allowing physicians to move to these models and having them exit the insurance-based systems and the Medicare, Medicaid, the public payer systems, was a net negative for society because this meant fewer primary care physicians, and this was introducing primary care access gaps for the folks that were left behind in that insurance model.
I think that's echoes of the Maoist arguments, right? Is that we can't have privatized farms because how will we ensure everyone has food if we don't collectivize it all, right? It's sort of a socialist type bent there. Sanat, what are your thoughts?
Well, on this, that's one of the articles I wanted to dig into a little bit. I'll just go on a little bit of a tangent here and bring up the corollary that I was going to speak about. The thing that got me most excited was Zhibai's paper that she published about actually decoupling primary care from insurance. And I thought that was a very, very pragmatic path forward. And we were already seeing elements of that in the past 10, 15 years with the direct primary care model. I'm always fascinated by how many of our colleagues that are with an academic bent kind of echo these similar sentiments of almost trying to evoke some sense of shame from us for wanting to pursue something that's going to improve our quality of life or improve the way we practice medicine. Sort of like, no, you're just supposed to be here to look after the patients and we'll take care of everything. Maybe I've read too much Ayn Rand. I think they take great umbrage with that position. Anish, I haven't read that article. Did the author come up with some sort of, what was the conclusion other than if you do this, you're bad? I mean, what was some of the meat of that article that you picked up on?
Yeah, it was essentially an op-ed talking about the problem that DPC and concierge presents to society as a whole and presenting it as, a potential net negative. It's really amusing to hear that. Well, it's amusing and chilling a little bit. I think there's clearly a group of folks that are going to be very happy if every physician tomorrow wakes up as an employee of the state that we tell you what to do, we tell you who to see, we tell you when to see. You cannot, and it's dangerous for a patient to directly contract with a physician. I mean, that just will upend things. And to talk about this, my eyes rolled so far back into the back of my head hearing these MD PhDs from Harvard talking about the introduction of primary care access gaps because physicians burnt out by a broken system that you guys helped create. And to see that these MD PhDs they're academics, I want to know, how many patients are you guys seeing a day? Like, is not being an academic internist, is that not introducing, is your time better spent, writing these op-eds in the New England Journal, or is your time better spent seeing 40 patients a day in a poor part of Boston? You just talk endlessly about these primary care access gaps that other people are creating these problems, but God forbid you go out and actually put your feet on the pavement and see folks. So It's just a ridiculous article. But it's emblematic of the New England Journal of Medicine perspective page. When Dr. DiGiorgio is publishing in the New England Journal perspective page, I think we can all take it a little more seriously. I think hopefully there needs to be an awareness of the fact that, and again, widely read by young medical students, impressionable undergrads, etc., right? So it's really important, I think, for us to point out some of the major flaws in these kind of dumb arguments.
Well, Dr. Cho, in New York, there's probably not much room for a DPC type model with spine surgery, right? That's not something that fits that. But there is quite a big free market for spine surgery, especially in New York. I know that quite a few surgeons in the New York area take cash pay for spine surgery. Now, what are your thoughts on the free market perspective and whether or not there's a role for that? Is it going to leave people out in the cold, or do Medicaid patients have zero access to care in New York?
So when you look at this article, right, the title of it is Primary Care from Common Good to Free Market Commodity, right? And it's obviously taking a slant that what does common good actually mean? You're labeling primary care and all primary care doctors as everyone has access to it, everyone has the right to use it, and who's going to deliver it, right? At the end of the day. So let's say that Kobe beef, it should be a common good. Let's make all the steakhouses open up their doors and make sure that everyone has access to Kobe beef, right? It just doesn't work that way. And this is the total ivory tower. You could see it, MD, PhD. You can sit these authors down and interview them and ask them, have you ever set up a primary care clinic? Have you actually set up the front desk? Do you know what it takes to build an EHR? Do you know what it takes to even buy seats for your waiting area? And ask them, do you know what it takes what's the overhead for a primary care practice? And then kind of reverse engineer from there and ask them to increase access to a population to primary care. You need to make the finances work, right? And you look at how primary care has been reimbursed. They use E&M codes. Medicare, I'm familiar with the E&M codes. For our practice, when we bill Medicare for 99203, I think, which is a follow-up level 3 visit, right? That's I think it's $110, right? $110. And this is my poor primary care colleague who, look, for surgical practices, 99203, not that hard of a visit. I'm in there, I'm focused on one subspecialty problem, neck pain, back pain. My poor primary care physicians there are managing 8 comorbidities, trying to check a hemoglobin A1C, then check a lipid panel, then check a thyroid. I know they're going through all these systems. I have my spouse who's an oncologist and who tells me to manage just even oncologic care, right? They're like the oncology patient's primary care, and she's telling me what she has to manage per patient that walks in. I mean, I don't understand how 30 minutes of a physician's expertise to manage 8 different systems at a level 3 is. How can you value that at $115 for a 30-minute visit or a 15-minute visit? It just doesn't make sense to me. The finances don't work, and you can't cover your overhead. And so DPC is just a manifestation of when you have price setting, you have shortages. Okay, why is there a primary care doctor shortage in America, and why have PAs and NPs been pushed to fill in the gaps? Because there's price setting. You had price setting. You set the bar so low. Primary care doctors are getting paid less than plumbers, less than construction workers, and arguably probably fast food workers at some point. And you expect that model to be sustainable. It's not. And so DPC is one way primary care doctors who are entrepreneurial, and also really most of them have stayed in the market. And I know a lot of DPC primary care doctors through the Organized Medicine, AMA, who have fought to keep this model alive and not to be overregulated. They're there for their patients. They want to stay in their communities. They want to stay plugged in. Rather than getting bought out by private equity or a health system, they want to stay independent, and they want to be able to serve their patient panel. And yes, there are going to be some patients that can't maybe afford the concierge fee. I know in those cases, you're not working with a corporation, you're working with a private practice. The physicians can do sliding scale payments and make sure it fits the patient's financial needs, and they keep their access intact for their patients. So it's a net positive win for a community when DPC it functions. And it's a product of a failed economic model and healthcare that has strayed from free market principles, which is contrary to what this article says.
And I think the economics. Go ahead, Sanat.
Well, I was going to ask one question. Where exactly does the authority come from this crop of people to sort of, I understand it's an opinion piece, but we've encountered this ourselves with some of our interactions. There's a certain sort of moral authority they sort of garb themselves in that says they have the right to sort of make proclamations like this. And we, because of whatever status and standing they have in their minds, we have to listen and bend to them. I'm always fascinated by that.
Well, I think Harvard is largely the architect behind the prospective payment system, right? William Tsao, who did a lot of the legwork, and the original CPT codes that were valued were the Harvard valued code. I think a lot of that stems from that. And so when Harvard is being targeted by certain chief executives of the United States, I am not shedding too many tears because unfortunately, they just get the basic economics wrong. Like Dan said, they don't realize that price setting causes shortages. Just in their framing of the article, they label primary care as a common good. If you look at the basic economics has definitions, right, of public goods, private goods, common goods, and club goods. And it depends on whether the good is considered rivalrous or excludable. So for something to be a public good, it has to be non-rivalrous and non-excludable. The classic example, right, is lighthouses. You can't determine who gets to use the lighthouse or not. And your use of the lighthouse doesn't diminish someone else's use of it. So common good is rivalrous but non-excludable. And primary care is not that. You can exclude people from your primary care clinic, right? If you just walk in a random primary care clinic and demand an appointment, they're going to send you out, right? So that is an excludable good. So primary care is not a common good. They get the basic economics wrong. And when they get the basic economics wrong, I think they get a lot of the downstream effects are completely off. I was having a discussion about HSAs in the context of DPC with some very left-leaning health policy experts here in the Bay Area. And because there's a resolution up for the CMA to expand HSA options to any sort of health insurance. So people on Medicaid would ostensibly have access to HSAs, which I think would be a huge step in the right direction. But the arguments against it that came from some of these colleagues, number one is that Medicaid patients just won't be able to understand it, which I found pretty insulting to that patient population. Number two was, I have an HSA, but it's really for people who make money because there's tax benefits. So we shouldn't let people who don't make money have an HSA. And number three was, they're going to be predatory, right? Because if you have control over your own dollars, somehow you're being taken advantage of by some large system. So I think these arguments that just come from basic misunderstandings of economics, of personal responsibility, of personal control of your own spending, because they view this healthcare as a public good. They think it's the same as firefighters or military protection or things like that. They don't view it as a normal private good, which it really should be. Primary care really is, it's rivalrous, it's excludable. If I'm in a doctor's office, he can't see somebody else at the same time. And if he doesn't want to see me, he can kick me out. So I think it really meets the definition of a private good and should be treated as such. Anish, what are your thoughts? Go ahead, Dan.
I'll be short, but I think it gets down to that philosophical question, right? They always point to, is healthcare a right or a privilege? For me, that's of course, healthcare, basic healthcare, we should try to give as much people as possible. As doctors, we want as many people to have basic healthcare, right? But it's just an irrelevant question because you can't service and you can't produce enough services if you don't have market forces working for you. You can't call it a right if you don't have enough of the good to get around. It no longer is a right or anything. It's just a failed system, right? And so the question here is, how do you promote output? How do you encourage more production of healthcare services? And that's not the question that's being asked in Washington, D.C. It's just, okay, work with what we got. And even though we're losing doctors and doctors are getting burned out and all we have are PAs and NPs who haven't gotten to residency, we're going to somehow increase output that way. It doesn't work that way. That's the failed, that's why you can't ask that question, is healthcare a right? Because that's what they always flip it on you. But for someone who's pragmatic and trying to just figure out how to take care of more patients, that question is completely irrelevant to me.
Anish, what are your thoughts? Is healthcare right? Yeah. How would you answer that if asked by Elizabeth Warren in your Senate confirmation hearing when you're hopefully up for HHS secretary?
It's a great question. It has a political undertone. So you'd have to say, so what I've said for a long time is that whether it's a silly question because you can't make something right if it involves using or compelling other people's services. So that's not I don't think that's the right framing. What is the right framing is there's a moral justification for us to be able to provide a level of healthcare to everyone. Like we want to be able to quickly respond to somebody in a trauma on the highway, and we want to be able to quickly get them access to healthcare. So yeah, I think there's a moral justification for us to figure out how to deliver healthcare. But in that is a lot of stuff that we want to try to sort out, sit down in society to try to figure out how best to do that. And certainly our approach to it has been disastrous in terms of trying to take a square peg and fit it into a round hole in terms of trying to treat healthcare as a right that we have to get to everyone, and not discussing some of the very hard things that get beyond some of the emotional appeals. So that answer would get me kicked out of the confirmation hearing.
Well, but I think it's something. Go ahead, Anish.
I guess the issue is just not. It brings in the whole CBO thing, right? I mean, look, I get what they're talking about when they're talking about common goods, right? The issue in terms of rival-juris, non-rival-juris is that when you have a pool of physicians, and if you have a pool of physicians and you suddenly take 30% of them and now suddenly put them outside of the insurance market, the third-party payer market, well, you have a bunch of people that can't access those physicians. So in that case, there is, the two people can't use that particular resource, but just like the argument that the folks today are making against Elon, I have no great understanding of whether or not who's right in that whole debate. It assumes that the supply of folks is fixed. So if we've created a system that is actually decreasing primary care access because we have not aligned incentives to grow the primary care pool. So this whole business of rivalrous, non-rivalrous good, I think I understand where they're coming from, but I think what they're missing is that you have created a system which is creating that primary care access gap, right? And if you have a different system, if you embrace it and you give up some control, which they never will give up, which is why I don't have a huge problem with trying to go after these academic institutions to make them less relevant. But what they have to do is really work to increase that pool of primary care folks, increase the incentives, and that is found in the direct primary care and the concierge movement. The direct primary care movement is not like concierge care. You don't have to be super wealthy to access direct primary care, right? You're talking about $50 to $100 a month in some cases. There's a big sliding scale, and that covers a whole lot of things. When you're talking about people with a bronze plan who are healthy, who have a $6,000 deductible, I mean, come on. You may as well have that as a catastrophic plan, plus have direct primary care. But anyway, I think there's a lot to discuss.
Well,
that's kind of how I would get to it, yeah.
So let's use that. Let's move on to, the big thing in the news is still Medicaid and how millions of people, billions, trillions of people are going to die if the big, beautiful bill is passed and everyone is stripped of their health care. They'll have to go back to leeching and bloodletting to treat any sort of disease, if you were to believe what is on the news. So what do you like about the big, beautiful bill? What do you think is there anything good in there in Medicaid? And if you were to have your option to make some changes in Medicaid, we're all a kind of free market adherents. I think this is the one area that we do struggle a little bit with, is communicating how this is a good idea to embrace free market principles for those who may not have the means to go and even $50 to $100 a month for direct primary care. So, Dr. Dixit, what do you like? Where would you go with this if you could?
So I haven't dug into a lot of the things in the One Big Beautiful Bill, OBBB, but just looking at it superficially, I know the first thing that pops up is the thing you've been championing, which is the work requirement for Medicaid. Everybody throws out the statistic. The CBO says 8 million people are going to lose their health insurance, 5 million because of the work requirement. I'm just like, okay, so when's it's like the flu vaccine. If they pick the strain right 40% of the time, CBO is usually off in their projections. What I thought was interesting was the rural emergency hospital, and how they were actually going to supplement some of these critical access hospitals that have been shut down. And they've got very strict criteria for how they're going to fund these things. That's not something you're hearing a lot about. And Anthony, maybe you probably know more about this than I do. That's the part that I paid a little bit of attention to. I'm like, okay, so they really are trying to flip the switch on this access question. On one hand, you're getting they're supposed to be making these draconian cuts for the Medicaid population. On the other hand, there's an estimated 380 critical access hospitals or REHs that are going to receive funding to be able to provide care in these rural communities, the places where they actually need them. It's just, I found we can't just look at the policies and the bills for what they are. We always have to have some sort of political spin, and everybody's guilty of it. I know I'm guilty of it. Most people are, but when you get right down to brass tacks, it's just like, okay, what are they trying to do, and what's actually in there? And when you look at the mechanics of these things, what's actually going on. Yeah, there's some other fun things in there, like you can write off your health club expenses or some sort of things like that under your HSA. I think a lot of the chatter, a lot of the incorrect interpretations get taken as a blanket fact and get parroted by a bunch of people. The actual meaning and the actual substance of what's out there gets lost, but it's by design. It becomes a talking point to gin up an emotional response. And the topic is already so flipping emotional, you don't really need to gin people up all that much, but it's basically one of two things. People are going to die, and you're a greedy bastard if you let them die if you don't do this, or you're greedy bastards for not giving away your services if you're a direct primary care doc.
Right.
I don't know. The Medicaid stuff is, we can go around in circles on that. I have my own view on that. But the rural hospital thing, I thought that was very interesting.
I think that if you really look at Medicaid, what Medicare and Medicaid, what was the original intent and design of these programs? They were safety net programs, but they are not being treated as such currently. They are being treated as, the language being used is, people are going to lose coverage. People are going to lose coverage. Okay. They are going to lose coverage because the Medicaid program has been expanded to no longer be a safety net program, right? And people might disagree that it's a safety net program. It's not supposed to be a safety net program. So then now you're talking about single payer. If you're saying that this is not a safety net program, right? You're talking about how do we expand coverage that's government funded for more and more of the population. I just have some numbers in front of me that you guys, I think, will find interesting, is that just Medicaid enrollment by year, starting in 2010, pre-ACA, baseline was 66 million in the United States. It got up as high as 92 million in the country in 2022, and then kind of settled back down to like 79 million in 2025. Now, break this down by state, right? So different states have different viewpoints towards whether Medicaid is a safety net program. I work in New York, and I've firsthand seen the population get more and more coverage through Medicaid. Now, they introduced this program here. It's managed Medicaid, right? And kind of curious, right? It was a government-run safety net program. Medicare used to be just a government-run safety program, and somehow now it's been commercialized, and it turned into these managed Medicaid programs, they call it. And you have these for-profit insurers who are now involved in the Medicaid game. United Healthcare, actually, United Health Group has an arm similar to Optum or other arms, the arm that runs the ambulatory surgical centers and their hospitals. They have an arm just for Medicaid products because it's profitable. And what they've done is push some of these products in certain states that are more friendly and welcome to expanding Medicaid. And in New York State, that's exactly what's happened. I see United Health Community Plan. That's what it's titled. It's very confusing. It looks just like a employer-sponsored. The card looks exactly identical. You can't really tell them apart. Our front desk we had a hard time deciphering which one was commercial versus Medicaid. And the plan benefits are completely different, obviously. And in 2010, New York State was at 4.7 million pre-ACA baseline. It steadily increased. 2016 was at 6.2 million. 2020, 6.8 million. 2025, 7.2 million from the starting point of 4.7. So it almost increased 40%. California started off at 7.2 million in 2010. And in 2025, it doubled. It's at 14.5 million. This is a Medi-Cal program. And I'm sure, Anthony, you're very familiar with this. Now, this is just looking at these numbers. This is not accidental, okay? It's not that all of these patients are living below the poverty line and can't, this is by design, right? To expand the government-funded healthcare on a path to hopefully those who designed it to a government-controlled single-payer system. And this is all part of the design, in my opinion. And you look at Florida is different. Florida's 3.7 million in 2010. And then by 2025, they're at 4.2. Right? So completely different policies about what they're labeling the safety net to be? And I think that's the key question. And as you expand the safety net, I see it here in New York more and more. If you're middle class here and you have a salary job, it makes sense to go on Medicaid. Your benefits are sometimes they're even better than commercial plans. That's what people have
Low cost
argued here
sharing.
in your exactly. So, I'll kind of end with that.
The big picture thing that I like about the current bill is that it kind of tries to go after some of the gaming that states have done to attract additional funds, right? And I think that's the issue. Look, if California wants to, set up some beautiful safety net program that covers 40% of adults and does a good job at it, go ahead, do it, but keep it within the California state budget. Like, don't draw down from the federal government to make your system work, right? Because then every state is going to set up some type of weird program that attracts the most amount of federal dollars, which is what has happened, right? And so you have all these arcane things that, unfortunately, the people that are emotionally talking about Medicaid cuts and blah, 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 don't understand, right? Is that you have these provider taxes, right? The provider taxes is a tax on healthcare providers in the states to fund Medicaid. Okay, that sounds great. But if you do that, then the federal government matches that. And that increases the state budget. And so the state doesn't have to actually do the work. And so I like the big picture approach to try to go after this, to be like, all right, you want to set up this program, it has to be fiscally responsible and has to make sense within the state. We're going to stop subsidizing you from the federal government, not necessarily because we don't want to do that. It's because we are broke. We have $36 trillion worth of debt. We will not have a safety net in the future if we keep spending like we're spending. So those are the big picture things I like.
If we default on our debt, there will be no safety net. I think that can be your catchphrase there. So just, I think, some more numbers that are interesting. The original Medicaid statute covers a very discrete population, right? Poor children, poor pregnant women, disabled, and poor elderly. For that discrete patient population, every other expansion outside of that is technically optional, including the ACA expansion population, the able-bodied poor, right? That is technically an optional expansion. There's an interesting piece that came out of the Manhattan Institute where they looked at the amount of spending. 63% of Medicaid spending is on optional enrollees outside of that standard enrollee class. 22% of that is on ACA expansion adults, and 41% is on groups that aren't even covered by the ACA expansion, right? So as you're mentioning, states can expand and expand. Here in California, we can, in some cases, cover people up to 400% of the poverty line in Medicaid, just with various what they call demonstration projects. So there's this huge, massive expansion of Medicaid, and you're right, a lot of it is drawn down by the federal government. The way that the provider taxes work, and I have a little bit of a mixed view on provider taxes, because the way the big beautiful bill has come out is it caps provider taxes where they are. So states like California and New York that have really exploited the provider tax system are essentially being rewarded, while other states that have used it but haven't used it to as big an extent are basically getting capped where they have. So they're almost getting punished by being a bit fiscally conservative. States like Texas and Florida, there's some rules about provider taxes about being under 6%, and we can get into the nuance. It's pretty wonky, but basically Florida and Texas have been more at like 2 to 3%, where California and New York have maxed it out, and they're getting punished a little bit. The conservative states are getting punished by this new bill. So I think there's some more nuance that they can hopefully work out with this bill being in the Senate. But I think thinking positively, what can we do to improve Medicaid? And I think this can go back a lot to what we've spoken about with direct primary care. Anish, you and I published a piece on our Substack talking about making a DPC benefit for Medicaid. And I was just doing some back of the envelope calculations looking at this. The average Medicaid beneficiary, the average ACA expansion beneficiary, so this is a young, healthy, poor person under 138% poverty level. We spend, combined state and federal government spends about $6,500, $7,000 a year on that person. I highly doubt that most healthy, poor 35-year-olds are using $6,500 worth of healthcare services in a given year, probably using very little. So you can give them a DPC benefit. You can give them the catastrophic plan if we were to make catastrophic plans legal again. And that would probably cost about $4,000 a year. So you're left with $2,000, $2,500 a year that the federal government could just deposit in an HSA for them. Now you have them growing wealth over time. You have it so with their catastrophic plan, they will be able to meet any sort of deductible within 4 years with a normal rate of return on that HSA investment. And then by the time they retire, if they start around age 30, by the time they retire, they're going to have $250,000 in that HSA. So for someone who's living below the poverty line to get this sort of subsidy, Not to mention they're going to get better access to care. They're going to be able to get a DPC doctor instead of having to wait 6 months to see primary care. They're going to be able to get access to basic imaging and labs. And yeah, they'll have a little bit of cost sharing, but they're going to have so much money in their HSA after a couple years. Hopefully by the time they need to pay for cost sharing, they will have the funds to do that. So I think if we take this shift and go, again, more towards this free market, there's a very good way we could have free market principles cover our Medicaid beneficiaries. And then once you take that whole population out, now we're going back to just using Medicaid for that original intended population. We've gotten rid of that 63% that's being spent on these optional expansions, and we're just focusing Medicaid on the poor, the disabled, people that really have no means to go into a DPC type system and use it as a true safety net, I think, as it was designed. Any thoughts on that?
Yeah, no, that's great. And the crazy thing about the opposition to a DPC is that it's literally a capitated payment per month per patient. It's essentially what they would want, except they are so focused on having it go to some one big beautiful system. You know, you talk about the one big beautiful bill. They want it to go to one big beautiful system. All the money goes there, and then there's this lots of leakage that happens, and then they have to like figure out how to get that money out, and everyone's trying to bill them and stuff. And it's like, my God, why are you so opposed to it? You're opposed to it because you have to give up control, right? Like, God forbid. I mean, if you did what Anthony just suggested, right? If you set up a system where on behalf of Medicaid, we were going to give $100 a month to DPC, you choose, you, the patient, choose $100 a month that goes to some DPC physician, right? And again, that's coming from the state or whatnot, state or federal or some combination of the two. I mean, the number of physicians that would in droves move towards DPC like overnight would be huge. And that's also the problem. That would kind of decimate the current model of healthcare that they've worked so hard with. That's great. That'd be great. And the question is, how does one?
Your number's actually worse than what Anthony's saying. I was looking at this strictly piggybacking on what Dan said, looking at some of the third-party administrators. See, this is what people don't understand. They want a single payer. They want centralized services. The federal government cannot administer all these plans. So they have to farm them out to Blue Cross under Elements. They have to farm it out to Centene. They have to farm it out to Molina Health. They have to farm it out to, whomever. And there is a lot of money to be made from these MCOs in basically managing these patients. So I looked at how many lives Centene covers. Centene covers more Medicaid lives than anybody. It's about 13 to 15 million. And if you looked at their total revenue versus their lives covered, and we know they're not spending this much, but on a per capita basis, you're getting into around the $18,000 to $20,000 per member value creation for the lives that they cover. And they're making their money on a PMPM model. They're making their money off of the PBMs and some of the other things. But I would just think about that. If you had $250 million going into a kitty, where is that money better deployed? Putting $6,000 to $10,000 per beneficiary and say, here, we'll put that in HSA, or giving it to Centene Healthcare to basically manage and basically try to arbitrate a couple of things. It's fascinating. They're covering fewer lives. These Medicaid plans are covering fewer lives. They're making more money and their CEOs are making more money. That's the disconnect over here. So it's like you are actively that's my issue. You are actively incentivizing these third parties, these insurance companies that you claim not to like, Luigi Mangione fans, you claim not to like. You're going to make them even wealthier and more consolidated. The other thing is they don't do a very good job. They don't do a very good job managing the funds. They don't do a very good job managing the patients. I keep going back to that Wall Street Journal article from about 3 months ago, where they said there was about $4 billion of taxpayer money over the span of 2.5 years that went to Medicaid to basically cover people twice. Because if they're in the state of Georgia and they move to Tennessee, they have no way of figuring out, hey, this person's no longer in Georgia, but they're still paying Centene for that patient. I'm like, it's inefficient. It doesn't.
Well, I'm not as down on managed care organizations, I think, as you all are. I think that they're a natural response to the fact that you need some sort of utilization control, right? If the algorithm is send a check to the government or send a bill to the government, sends a check to the doctor, there has to be some sort of utilization control. And I much prefer private companies do it over the government. That being said, there's certainly a lot of room for process improvement. And in the realm of Medicaid, one big area for improvement that I like in the big beautiful bill is eligibility verification. And that what you're talking about, Sanat, is absolutely right. There's people enrolled in multiple states. There's people who have died. There's people who actually have private insurance but are still on the Medicaid rolls. When the federal government picks up 90% of the cost, the state has little incentive to put a big effort into eligibility verification. When the MCO is receiving that per member per month check, it has very little incentive to verify eligibility. So a lot of what's in this new bill is just about eligibility verification, including the work requirement. I consider that some as a form of eligibility verification, the fact that you have to check in on these people and making sure that they're working. So I think that all these things are good in that you will tighten up the eligibility, and then that will decrease the amount we're spending just because the roles are going to be more closely aligned with reality. People are going to scream like their hair is on fire because the number of enrolled has gone down. But in a lot of cases, people aren't actually losing coverage. They're just not counted as having Medicaid anymore because, hey, they've actually moved on to a commercial plan, or they've died, or they're enlisted in 2 states. But of course, people, again, are going to scream like we're condemning everyone to a slow, painful death because we've taken away their duplicate Medicaid card in 2 different states.
I think that one of the other questions to ask is, you're increasing coverage, right? Or, Medicaid has expanded its roles, but how does that actually translate into more care, right? Is coverage actual care? And again, that all boils down to access and healthcare services production. Like, are we servicing the enrollees? Are they having access to care? I can only speak firsthand from New York. It's interesting because New York State has a pretty robust managed Medicaid program, and it's arguably just as good as most commercial products in the state. And us as a private practice, we actually accept managed Medicaid because the legislators actually were convinced in order to protect access, they were actually willing to utilize some free market principles to allow there to be some market-based fees for services. So surgeries performed on a managed Medicaid program patient, then you can actually go to an arbitration system here in New York State and kind of argue with the insurer, not the arbiter. The arbiter decides who has a more fair offer for the payment, which is more market-based, right, than usual Medicaid program saying, here's $100 for your surgery. That's the Medicaid fee. It's fee setting. There's actually a more market-based system. And so that's one way you can improve access, obviously, is introducing these type of free market principles where you're not price setting, you're letting the market dictate the rates, and then more physicians are willing to take on those patients, and you increase productivity and increase access. And so I would say, even though the managed Medicaid as a principle, I kind of see it as an inappropriate expansion of the safety net, you can make it work for patients if you introduce free market principles, in my opinion.
Can I ask one
That's
question?
not just a blue state thing. Just one point is I've talked to spine surgeons in very conservative states who actually have that same deal where they get reimbursed near commercial rates for Medicaid managed care. So Medicaid's a state-by-state thing. The states get to have a large say in how much doctors and hospitals get reimbursed. Go ahead, Dr. Dixit.
Yeah, so should we be carving out the kids in the Medicaid discussion?
They're under CHIP, which is Medicaid and CHIP. But yeah, and I think largely Medicaid or CHIP pays a little bit better than standard Medicaid, and a lot of pediatricians are pretty happy with Medicaid rates. But I think that's a good point.
Have you come across anybody where the parents were on commercial insurance and the kids were on Medicaid?
Absolutely. Yeah. I have a good friend whose daughter was born with a birth defect, and she is now covered for life under Medicaid while they still have commercial insurance. And I think that, again, that's a good thing. That, lowers the risk pool for the commercial payer. They don't have to take all of this. It is somebody who is going to have a lot of healthcare expenses. So I think that is totally appropriate. And again, that's what Medicaid is built for. It's for these people who are probably never going to have an option to exist in the commercial market. But for someone who is just temporarily poor, I don't think that there's a reason to exclude them from the commercial market. Anish, you were going to say something.
Yeah, I just think we got to be careful about it. It'd be nice to see how these programs work without that kind of, the federal government coming in and putting, a pile of cash on there that then ends up in frankly, doctors, providers, et cetera, pockets. Because, the longer term goal is not to kill the golden goose of American healthcare. So, I still think that, I still think that we need to figure out how to, as we talked earlier in the discussion, figure out how to have Medicaid be there as a safety net for the people that really need it, for the people that, And if Medicaid truly is for folks that are indigent, right, and the federal government is providing, meaning us, taxpayers, are providing some safety net to them in the form of, look, we're going to reimburse providers to take care of these folks. How should that market function? Meaning, it's a hairy question that gets to philosophical and
it's
ethical.
a slippery slope.
Yeah. And
it's a slippery slope.
I had a good discussion on X earlier today where we ended up talking about Rousseau with the whole Medicaid discussion. And we sort of went down a rabbit hole of, it was largely on the work requirements, but this other person was making an argument that ensuring people have Medicaid is a greater good because it theoretically keeps people healthier, keeps the ERs from being flooded, considered it a public health investment. And that if we don't ensure that they have low cost sharing and are covered, then they're going to make bad decisions and they're going to end up costing more down the line. And I think that this really gets into this Rousseauian concept of the greater good, as he puts it, that we have to be forced to be free for society's benefit, which I, ever since COVID, have completely rejected that idea, because I saw what kind of authoritarianism can be unleashed when we prioritize this greater good over personal responsibility, over personal accountability, and over personal freedoms. So I am a very hardcore anti-collectivist at this point, but I think that really is a philosophical difference. When it really cuts down to the core of it, is how much personal freedom do we want to allow people to have? If we're going to say everyone needs to have Medicaid because we want them staying healthy so it doesn't cost more down the road, is that also give license to restrict behavior that could lead to injury or behavior that could lead to bad health? If you're saying we're paying for your Medicaid, now can the state come in and say, well, you can't go play tackle football and you can't eat sugary drinks and you can't do this because it might cost us more down the road? Really gets into that slippery slope. And that's why I have become, especially since COVID, a pretty big anti-collectivist.
Well, the NHS already does that for knee replacements, certain joint replacements, certain spine surgery. I think it's BMI or their latest corollary. If you're above a certain point, you ain't getting the operation. That's the problem when somebody else, if somebody else is paying, they're making the decisions ultimately about what happens. And that's the thing that I think they also don't fathom, is just, you don't have an unlimited debit card. The government is going to ultimately be deciding on winners and losers. And ideally that power should reside in our hands and the patient's hands, but some people say
it screws up the incentives hugely if Medicaid isn't something you want to get off, So I don't know, but that leads to some difficult questions. But again, if Medicaid is going to truly serve as a safety net, yes, you don't want to be able to buy caviar with your Medicaid card. Caviar being Dr. Choi.
Never had caviar, actually, believe it or not. It doesn't look that appetizing.
Oh, it's delicious.
That's great.
Yeah, check it out. The whole personal responsibility thing. I mean, you see it in the culture wars now, where you have Sports Illustrated celebrating obesity, right? You have,
before the GLP-1s.
There is,
yeah.
But there is this movement. You see it, and you look around. I feel like I'm living in like a bizarre world. Like, you're celebrating a health condition that will kill people, and you're normalizing it, and you're saying it's okay, and this is, you got to accept everyone for who they are. And I think this also comes down to the crux of why there's such a resistance against the MAHA movement, because the MAHA movement, really, a big part of it has to do with personal responsibility. You have a choice to think about what you're going to eat every day. I mean, yes, some people live in food deserts. A lot of people live in food deserts. There's some systemic things that need to get worked on. But again, a lot of those food shortages are all like, something got messed up with the free market. That's why the supermarkets are not there giving out produce or selling produce. But it's this movement about this. The MAHA movement is, I think, essentially about personal responsibility and choice and making good choices for your family, nutrition. And you have to put in the work. Like, you have to get unaddicted to processed foods and unaddicted to added sugar. I mean, I've gone on a personal journey myself. I was addicted to sugar for decades and didn't check what added sugar was put into any of my food. I just said, this tastes good, that tastes good. And then like 20 years later, I looked back and I was like, wow, chocolate, Silk, soy milk tasted good for 10 years because there's like 20 grams of added sugar per serving, right? So, all these things, like, some of it is education, culture, but I think that health inherently, unless we're going to bankrupt ourselves, has to, look, there's a spectrum. I'm not saying put it all on everyone, personal responsibility, but you got to let the pendulum swing back towards people being held accountable and taking account for their own health. And we have to educate and really give and support our population on how to make themselves healthy again. And I think that's what the MAHA movement is about. And I'm a big supporter of it, of that aspect of it anyway.
Yeah, poor personal decisions have downstream effects, but what also has downstream effects is treating everyone like children and assuming they can't make their own decisions. And we have a lot of that, I think, infantilization, which again is going back to this idea of allowing people to opt to change their Medicaid benefit into a optional HSA DPC catastrophic plan combo. That really incentivizes good health, right? If you're sitting there watching your HSA grow over time, thinking, hey, if I stay healthy, I got to keep this in retirement. I think that's a pretty good motivator to stay healthy, right? And again, the counter argument is, oh, well, they're going to delay necessary care because they don't want to spend that money. But again, I think that's a level of a coercion and that greater good type thing that we sort of reject from a Hayekian perspective. If you give a million people or 100 million people the ability to do this, in the long run, that's going to be much more effective at long-term health and better outcomes than any central planner could ever hope to achieve. And so that's why I think empowering people to take control of their own health is really the way to go, especially in Medicaid, where these people have the opportunity to live healthy lives. Just because they're poor doesn't mean they're going to spend a whole lot of money on their healthcare.
And just like empowering patients, you're empowering physicians to take control of their own destiny, their own economic and professional satisfaction and freedom by a DPC model. And I would really, if I had ever got to interview the authors of that article, going back to it, it's like, what drove those two authors to write that article in New England Journal of Medicine, right? They are in the academic world. They're trying to climb that ladder. They want to become a professor of medicine, whatever, of health policy. That leads to what? More titles, more prestige, more autonomy, potentially more leadership opportunities. You get to take home more to your family. They're being driven by very, I think to some degree, people are, doctors want to help our patients, but you're also trying to preserve your well-being, your sanity. You got to pay your mortgage, and you've got to give the power, independence, and autonomy back to the physicians to choose their own destiny, right? And everyone is always going to choose the destiny that's better for themselves and their families and their patients, yes, but no one's going to self-sacrifice and lead their own family and their own well-being down a terrible road, which is what consolidation has driven. And so DPC just allows power back to that primary care physician to choose their own destiny and also economic freedom as well.
All right. Closing thoughts, Dr. Coca. What are you looking forward to this week?
I'm looking forward to our next week's discussion on private equity, good or bad in medicine.
Yes, we didn't even get to touch that. There's been some good discussions online. I think that's probably worth doing some research. I know there's been people posting some things about the evils of for-profit hospitals. So I think maybe we should counter some of that.
But in terms of rounding out some of what we've discussed today, just a couple comments on what we're just going to say. We still have to deal with what exactly one does with folks that have made many bad decisions throughout their life, are in a bad place. And now what do we as a society do? We say, okay, you've smoked your entire life and now you have lung cancer. So therefore we are not going to pay for your we're not going to pay for your chemotherapy to treat your lung cancer. Are we not going to give you diabetes meds, or we're not going to give you weight loss meds, even though you're 250 pounds, and likely because you've made a lot of poor food choices for a variety of different reasons? These are, I think, really difficult things to grapple with. But I do think that breaking out of the current system that we have will allow for folks to have more access to healthcare. So I don't want folks to come away with the message that it's like we want to leave people out to dry, even though you've made multiple bad decisions and you ended up in a certain place. And I think that choosing a different path, like taking the finger off the scale of subsidies for some of these meds, or reducing the regulatory barriers to allow biosimilars, very similar drugs to be able to come out, reducing the amount of ridiculous patent time that some of these great drugs have, which means so many more $1 billion in terms of profit and stuff. I think there are lots, the system is somewhat feel rigged against you when you are 45 and you've made a lot of bad decisions and you're living in a difficult place. And I think they're right about that. And we have to speak to the fact that they are right about the fact that the system is rigged and their only hope is to get Medicaid and to be able to access all these resources. Why? Because if you try to get a GLP-1 at a store on your own, not too long ago, it was $1,500 a month. Now it's like $600 a month, right? But we have to really get at why those subsidies are high. If we don't do that, if we don't figure out how to drop the cost of care on the free market, which doesn't really exist, meaning if we don't try to continue making these movements, then I think we're just going to fail. So I think we really have to focus on that, and we have to hit hard over and over again. I think that reducing that federal subsidy, the taxpayer subsidy, the government subsidy that's going to a lot of folks is in large part, what's keeping the cost of healthcare high.
Sanat, final thoughts?
I was very excited, again, when we were talking about Medicaid and we're talking about primary care, Dr. Bai's article from Johns Hopkins. I think it's a blueprint. And I think being able to expand upon some of the things we're conceptualizing and say, here's what a blueprint could look like if we did X, Y, and Z. Maybe that's not going to necessarily tie into Medicaid per se, but economically and just from a market standpoint, it makes absolute sense to decouple primary care from the insurance. And I was very excited to hear more people talking about that. And I think this ties into what we're trying to do with this podcast is, the feedback many of us get is you're rich doctors and you're just trying to preserve your incomes. No, it's not that. It's really it's very much about power, self-determination. And I think that means more to us than anything else. We don't want to have our hands tied. We don't want to have somebody else, some third-party bureaucrat telling us what the best way to practice is, when to practice, who we can see, how much we can make. It's very stifling and it's counterproductive. We also don't want that for our patients. I think those are the messages that we continue to share because I think that's empowering. There's going to be a segment of society, I don't know whether it's 15%, I don't know whether it's 30%, that will never get it. And they'll always need some sort of handholding. But for everybody else, conceptually, what are we trying to do? We're freedom, liberty, self-determination with something of a safety net. We need to find ways to sort of expand upon the things we're conceptualizing and make the words flesh. So I'm very excited about it.
Totally agree. Safety net is essential, and that's why I work where I work. And despite people posting my salaries online, I'm really not that rich.
You're underpaid.
Right. Thank you all for joining. Look forward to next week's conversation. Hopefully Dutch has returned from the land of Oz by then, safe and sound. We look forward to that. Anish, Sanat, Dan, always a pleasure.